Good afternoon and welcome to the Department of Behavioral Health Update. Today is February 4th of the year 2021. Hard to believe we're almost a year in, and here we are. February is Black History Month, and in honor of Black History Month, I couldn't play the song because it would be copyright infringement, but I did want to read to you the lyrics of a song that I find really powerful, sung by Billie Holiday, written by a gentleman by the name of Lewis Allen, named Strange Fruit. Southern trees bear a strange fruit, blood on the leaves and blood at the root. Black bodies swingin' in the southern breeze, strange fruit hangin' from the poplar trees. Pastoral scene of the gallant South, the bulgin' eyes and the twisted mouth. Scent of magnolias, sweet and fresh, then the sudden smell of burnin' flesh. Here is a fruit for the crows to pluck, for the rain to gather, for the wind to suck, for the sun to rot, for the tree to drop. Here is a strange and bitter crop. It's really hard to listen to that song. Even reading it is hard. One of the things that our Cultural Humility Committee did today, I wasn't able to join them, but they all chose songs and made some thoughtful reflections on them. How does that song make you feel? What does the song mean to you? What memories, if any, does the song bring up for you? What was the context in which the song was created, and what is the behavioral health impact of the song? I strongly encourage all of you during this month, maybe it's a movie that highlights the Black experience or a song written and or sung by a Black artist, to really use this month to explore the messages in that. It could be a book written by a Black author. We do have our racial equity library up and running now. And ask those questions yourself. Really reflect and think about what is the messages in that piece of art, and what does it say about the artist? What does it say about our society? And what can we do in the future to really think and utilize those experiences to become a more inclusive world. So thank you for indulging me to talk about a song that I find really meaningful in honor of Black History Month. All right, on to our COVID information. COVID marches on like every virus does. It's now almost 105 million worldwide who have had COVID and almost 2.3 million who have died of COVID. In the United States, we're over 26.5 million, over 26.6 million to be precise, who have had COVID, and almost 453,545 deaths in the United States. So we're very rapidly approaching 500,000 deaths. It is expected that by the end of February we will hit that very tragic and sad number. And in California, we are appearing to come out of our surge. We have 3.294 million incidents of COVID and now 42,466 deaths. We're testing a lot. We've done over 43 million tests in California and administered now close to 4 million vaccines. That's all really, really good news. The other thing is our positivity rate across the state is going down. We're down to 6.1% positive in the last 7 days. That was about 7.5% last week, so we're continuing to decrease. In terms of Fresno County, we're just under 90,000 cases now and just under 1,200 deaths. So we've really had a rapid increase in deaths over the last month or two with this most recent surge. If you look at the bottom graph, you can really see that spike that started in December and has been really throughout this last surge. Just steadily going up. And remember, as the surge happened, I always say this, you're probably getting tired of it. You'll see cases increase, then hospitalizations, then deaths. And as cases go down, you'll still see hospitalizations slow down after that, and then you'll see deaths slow down even after that, and that's the case here as well. So in terms of hospitalization, we are going down, 435 hospitalized yesterday. Just a little less than a month ago, that was 623 individuals hospitalized. Still pretty high in the ICU, to my earlier point, same number of people in the ICU as we had when we had fewer people in the hospital. And that's that same comment that hospitalizations lag cases, ICU lags hospitalizations, deaths lag that. And so we'll continue to see the ICU being utilized probably for another week or two. And we still don't have many ICU beds. Even though the governor did lift that stay-at-home order, we're still struggling with ICU beds. We only had 8 ICU beds yesterday out of about 150 or 60, so not very many. In terms of the tier system, which we're back to, we are still in the purple tier, but we're getting better. So 11.4% positivity rate. A reminder, we need to be under 8% to go to the red tier. 41.4 cases per day. We need to be under 7 per day. And then our health equity metric is 13.2 test positivity, so a little higher than our overall, and that needs to come down as well. That's where we look at our lowest census tracts and measure them to make sure that we're not looking good in just high income areas and such. Okay. So today I wanted to talk about vaccine effectiveness. This is going to become more and more of a question or a topic of conversation as more vaccines come online. Again, right now we just have Pfizer and Moderna, but there's 3 other vaccines in the queue, and some of them have lower effectiveness than our Pfizer and Moderna vaccines. So I wanted to talk about that. Pfizer and Moderna both are around 95% effective after 2 doses. Novavax is 89% effective after 2 doses. AstraZeneca is 62 to 90% depending on the dosage. And you may remember when AstraZeneca started reporting results, they had a 62% result with the amount of dose that the study was measuring. But they had a subset that accidentally got a higher dose. And those that got the higher dose, the effectiveness was higher. So that's why it's taken a little longer for AstraZeneca to come to market, because they recognized that maybe they could do a better job if they gave a better dose, so they've extended the trial to test that. And then Johnson & Johnson, which is the 1 dose, is 66%. Almost all of the 2-dosed vaccines have a similar or a little less percentage with 1 dose. You do get some effectiveness after 1 dose. So they are looking, they've started trials to see if you made Johnson & Johnson a 2-dose vaccine, would you increase the effectiveness? And so that really is something that's also being looked at. But you can see a difference there from 62, 66, 90, 89, 95. What does that mean, that effectiveness? Should you worry about taking a vaccine that has a lower effectiveness? So we're going to talk about what does it mean. In scientific terms, if a vaccine is effective, that means there was 0 illness reported. So if 100 people took the vaccine, and 5 people said, I had a fever, I lost my sense of taste and smell, etc., after they'd had the vaccine in the trial period, that would be considered not effective. And so the way that the vaccine trials work is you have a population of trial participants, and you never know what you got, but you have a population of trial participants that get the vaccine, and a population who get the placebo. They don't get the vaccine. Everyone gets vaccinated with either the vaccine or the placebo. It's done in the same exact way, under the same conditions, etc., and using the same needles, the same equipment, everything. And the people administering that vaccine, they don't know either whether the person they're giving it to is getting the vaccine or not. And then a period of time passes. And there's been a lot of questions about how did they get these vaccines to market so quick? They must have cut corners. They must not have done things right. And I've talked about this a little bit before. Operation Warp Speed, which the Trump administration pushed and funded, really gave that seed money that vaccine researchers and manufacturers needed to accelerate the process of procuring supplies and equipment and research subjects, et cetera, and really allowed the process to move faster from that perspective. But from a research perspective, one thing that helped these trials complete sooner is that COVID is really infectious. So you've got this group that got the vaccine and you have the group that didn't get the vaccine. And then time passes. And the passage of time isn't just a scientific construct. So it's not like a certain period of time means that it was a good study or not a good study. Enough time has to pass that the group that did not get the vaccine gets the virus. So you need enough people to get the virus, what you would expect to happen in the general population for people who didn't get the vaccine. And then once that number that reaches a certain percentage point, then you compare it to the group that got the vaccine. Did the group that got the vaccine get the infection, develop symptoms at the same rate as the group that did not get the vaccine? And the less infectious that a virus is, the longer that trial has to go on until you get enough people that it's scientifically valid to make that comparison. So that's one thing that really helped us with COVID and developing these vaccines is that people got the virus quicker in that placebo group, allowing us to say, okay, out of 30,000 people in the trial, 15,000 people got the vaccine, 15,000 people didn't. After 3 months, 1,500 people had gotten it over here and 10 had gotten it over here, or whatever that number was. Then you can make that comparison once you have enough people. And that's why we were able to get the vaccine to be approved quicker. So if anyone who got the vaccine develops the symptoms of COVID, tests positive for COVID and has those symptoms, it's considered ineffective for that part of the study group. And that's where you get that percentage. So for Pfizer and Moderna, 5% of the people who got the vaccine developed symptoms that were due to COVID. And it could be any symptom. It could be a fever. It could be a muscle ache. It could be loss of taste or smell. Any mild, doesn't matter. That percentage reflects in the not effective. And so when this effectiveness rate becomes important is when a virus has a high fatality rate. And what I mean by that is if you get the virus, you're going to die. Ebola's like that, huge fatality rate. So when you're developing an Ebola vaccine, 50% effective means probably 50% of the people, even with the vaccine, will die. That would be not so great. And you need a very effective vaccine for death if you're going to develop a vaccine for a virus that is highly fatal. For most coronavirus infections, and there's many, the common cold is a coronavirus, effectiveness isn't necessarily the most useful measure. Coronaviruses have been around for decades, if not centuries. It's considered pretty much a normal virus, kind of like influenza. There's lots of different influenza viruses. We don't panic. We don't shut things down when they detect cold viruses or flu virus, although occasionally sometimes we get a particularly lethal flu like the swine flu or H1N1, where all of a sudden it becomes a bigger concern and we start thinking about the types of measures we took with COVID. But we don't need to eliminate COVID to return to normal. We're not looking to have COVID not even be present in order to not have to worry about things like stay-at-home orders. We just need to change it from a deadly pandemic where a bunch of people get it and so more people die to a normal virus like every other coronavirus. So what is important about the effectiveness? 75,000 people have participated in the research trials, including all 5 vaccines. And that means 75,000 155,000 of the participants in the trial got the vaccine. So there was roughly 150,000 people, I believe, that's been in research trials, but not all of them got the vaccine. Not a single person who got the vaccine has died of COVID out of that 75,000 people. And that includes all 5 vaccines. Regardless of the effectiveness rate that you see, that percentage, no one has died. A very small number have been hospitalized, really almost inconsequential, but none of those have remained hospitalized 28 days after receiving the vaccine. So I haven't read all the details, but it sounds to me like most of the COVID that people got was either subsequent to their first shot or soon after their second shot, and their sickness was so mild that they were not hospitalized for that sickness 28 days after receiving the vaccine. Comparatively, for every 75,000 people in the general population, this is pre-vaccine with the COVID pandemic, 150 people will die. So for every 75,000 people in our population with COVID, with doing everything we've been doing, 150 people are dying, and several hundred more will be hospitalized, and hundreds to thousands will have some amount of long-term impact. Not everyone gets hospitalized with COVID, but some people take a long time to get their sense of taste and smell back, let's say, or are experiencing a lot of fatigue that doesn't seem to go away and such. So getting COVID has a lot more impact. And so much more than what we're seeing after someone's had the vaccine. For seasonal flu, for every 75,000 people in the general population, we typically see 5 to 15 deaths for every 75,000 people during flu season, and about 100 people will be hospitalized out of that 75,000. So much more are hospitalized with COVID. But going back to the prior slide, the people who had the vaccine, regardless of the effectiveness, no one died, and very, very few got so sick that they were hospitalized. This is fantastic news. This means even with 66% effectiveness, it could save you from death and save you from hospitalization. So what about the variants? All 5 vaccines appear to work against the British and the Brazilian variants. The South African variant appears to make the vaccines less effective. But it's really important to understand, less effective doesn't mean not effective. Less effective doesn't mean you're going to die or you're going to be hospitalized. It's just that percentage. It means more people might get symptoms when they get COVID. We don't know yet what it will do with deaths and such, and they are working on booster shots or think of it as a new vaccine that will address what the variants have done to that spike in the protein. But there's no evidence thus far that you will die. In fact, the Novavax and the Johnson & Johnson trials both had trial participants in South Africa. So no deaths of vaccine recipients have been reported in those trial participants in South Africa, and no serious illnesses have been reported. So that's the other thing to keep in mind. The variants are worse in that you can have a higher infectious rate, but it's still believed thus far that the vaccines still have an effectiveness against those variants. More people might get sick, but not necessarily die if they have the vaccine. So the bottom line is, we still have more information we want to know. What are the final results of Novavax and Johnson & Johnson? Those two particular vaccines haven't quite released their final results. We need to know those. We need to learn more about how each vaccine interacts with the known and future variants. But all 5 vaccines are good news. Less effective does not mean not effective, and preventing serious illness and death is better than waiting for a more effective vaccine. If you know that even if you got a vaccine that was 50% effective, you are significantly less likely to be hospitalized, significantly less likely to die, it's better to have a vaccine than wait for a more effective vaccine. The other thing with the vaccines, as we get new vaccines and we want to get them out, we don't want people, there were people that were offered the vaccine in this first go-round that said, well, I want to wait for this different one. Now we're not able to offer vaccines to those people because we have a shortage. And, you know, the more vaccines we get out, the less spread we have. And that's another important thing to remember about the variants. The variants happen with spread. That's the only way they happen. The more people the virus gets into, the more of our own DNA that it interacts with, and we fight it off, it develops different strategies to overcome our immune systems. And so that's how variants happen, is every time the virus reproduces, every time the virus encounters a new recipient, that's us, of the virus, the better chance there is that that virus could mutate and develop a little different genetic composition. And each mutation, some make the virus less infectious, and then that virus goes away, and others make the virus more infectious, and that virus propagates more. And so the sooner we can slow down that spread, that's why we want to use masks, that's why we want to have the distance. It's also fewer variants, and it gives the virus less of a chance to mutate in a more dangerous way, and the dangerousness being more infectious or more deadly. So that's another reason that we need to use every vaccine at our disposal regardless of the effectiveness. I hope that helps you understand it a little better. All right, so in terms of vaccines in Fresno County, the state has announced some new initiatives. Blue Shield will begin to oversee general vaccine distribution in the state in a few weeks. We're still learning what that will mean in terms of changes to the tier system. There was some discussion last week to shift away from particular populations and go strictly to an age-based distribution system. There's frankly been a lot of pushback on that from those individual groups in the current tier system, such as school teachers and frontline grocery store workers and different groups like that we haven't gotten to yet because we don't have enough vaccine. And their fear is if we go strictly to an age base, they'll just get passed over and have to wait their turn. And that might impact things like opening up schools or outbreaks related to factory work or grocery stores or things like that. The other thing is Kaiser will oversee vaccine distribution to special needs populations. Not really sure yet whether that includes the people who we serve, if that will be a system that we'll need to go through to get them vaccinated, or if we'll continue down the path that we're currently on, that we might vaccinate our population ourselves. There's a new registration system called My Turn. Those of you who registered to get a vaccine used PrepMod, and My Turn allows people to register with all of their demographic information so that the system can determine which tier they're in based on any of those variables. So it enables the system, even as the vaccine distribution tiers change, to determine whether or not it's that person's turn to get the vaccine, and then notifies them, hey, it's your turn, and maybe even schedules for them and tells them where to go to get the vaccine. We are still waiting to hear what role our local county agencies, public health in particular, will have in the new system. We're not entirely certain, based on current vaccine shortages, whether all of the vaccine will go to the new distribution systems, or some might still be reserved for the county to manage certain populations, yet to be determined. So stay tuned. As we learn more, I'll share that with you. Vaccine supply is still an issue, as I've indicated. We are more than capable of delivering more vaccines through our systems that have been set up in Fresno County than what we are receiving. So right now, today, we could deliver 15,000 to 30,000 doses a week, and we're on our way to be able to deliver significantly more. But we're only receiving 8,000 doses a week. And so unless and until the amount of doses that we receive increases significantly, our goal of getting to all eligible vaccine recipients by the end of the summer will not be met. And so there is a lot of advocacy going on right now at the state and federal level that if there is more vaccine, we need to get it, and to make sure that we're getting our, we'll say, fair share of vaccine compared to other counties and other parts of the state and regions of the state. And so that's something that I can really, really give you assurance that our county is on top of and making sure that they are advocating very, very strongly to ensure we get an adequate amount of vaccine, at least our fair share. All right, well, with that, I also wanted to give you a little update. There was a question last week about something that was on the CDC in terms of that interval of time between vaccines. So at our vaccine clinic, we administered the Moderna vaccine, and the interval for the Moderna vaccine is 28 days. And on the CDC website, it says if you get the second dose 24 to 28 days from the first dose, it's considered valid. It's effective. We're not worried about it. It does say on the CDC that they advise against scheduling the second dose in that window of time. But I can tell you with 100% assurance, because I checked with Ray Zbora, our interim health officer, and I asked some of the local hospital, everyone is following the interval, so 24 to 28. And the reason we're doing that is we need to get the vaccine out. And there's no reason to believe at this point that it's not effective. That second dose within that tiny little few day window is absolutely effective. That's what the study showed. That's why they say if you give it within that window, it's valid and okay. And so I do want to reassure you of that. We did check out that question. We are delivering the second doses this week and in the following 2 weeks. I will let you know that some people are getting increased symptoms after the second dose, not everyone, but there are some people who feel a little sicker, much like was reported by Dr. Tran after his Pfizer doses, that he felt a little sick for a little while, but these symptoms appear to resolve within a day or two. And a gentle reminder that those symptoms are your body's response. Its own immune system is recognizing that protein that the mRNA has instructed your cells to produce, and it takes about 8 to 12 hours for your body to get going. And then those symptoms are your body's immune response. When you get a cold, when you get the flu, and you get that fever and such, that's just your body fighting, attempting to fight off the virus. And so that's your body learning about that protein and teaching itself what it looks like so that when it sees COVID-19, it recognizes it for the evil that it is and gets rid of it. And so you might have some additional symptoms, and we'll work with that if you do. All right. My typical update, telework is going to be extended through March at a minimum. We're continuing to test. Please, please, please feel free to routinely test you and your family through the county's testing system. And certainly if you have symptoms, get tested. Even if you've had the vaccine, you should get tested and follow isolation and quarantine protocols if you either test positive for COVID or are exposed to someone who tested positive for COVID. Wear your mask, physical distance. All right, time for some questions. Someone loves the song. I love that song too, even though it's so, so sad. Someone asked about reinfections. Reinfections, while they have been documented to happen, are not perceived at this point to be a big problem. Remember, COVID became prevalent in the United States probably March or April of last year. We started our stay-at-home order in March, and more and more people started getting it through the summer. My son, remember, got it in early July, and so we're still in a window of time that it's believed that the real bolus of people who got COVID over the summertime and now will have some immunity. So while some people are getting reinfected, it's a pretty tiny number. It's not really documented at this point to be a significant issue. But that is why we're recommending that certainly after you're out of that 90-day window post-COVID, that you do get vaccinated. And so having had COVID should give you some antibodies, but because we don't know how long those antibodies will afford you protection, and certainly it affords you some protection, or people would just be getting COVID a second time all the time. We don't know how long that will last, so you are advised to get the vaccine, particularly if you're 90 days past that infection. Someone else said they got their second shot a couple days ago. Mild fever, chills, and body aches, but recovered in less than a day and feeling great. The clinic's super organized, so that's nice to hear. How are county employees that were not able to sign up to get the vaccine? If you email DBH Vax and you're eligible to get the vaccine, you'll be added to a waiting list, and if vaccine becomes available to us, we'll contact you. But because of the shortage right now, I can give you no assurance whatsoever that through our clinic you can get vaccinated. If you're a healthcare worker, you are eligible to get vaccinated at any clinic in the county offering vaccines right now. And so that's open to the public. So for instance, occasionally the Sierra Pacific Orthopedic Center is offering it. United Health Center at Central East has offered the vaccine. You can get it through a doctor or other healthcare provider, but you probably will not be getting it at the DBH clinic because we simply don't have enough vaccine right now to offer first doses again. If that changes, we're keeping that list in through the DBH Vax email, and that is enabling us to communicate with you. If you give us all of your contact information, we'll let you know if that situation changes, and if you still haven't gotten the vaccine, then we'll make every effort to get you in to get it. Any other questions? Oh, let's see. All right. Okay. This is not a question about COVID, but I'm going to go ahead and read it. It's a question about a reassignment opportunity coming out, but disappointed to learn that clinicians at Children's Mental Health are not being able to transfer due to program needs. I would tell you that I appreciate your frustration, and I will reassure you that as soon as we can get back to more of a normal situation, I know we have recruitments out right now for licensed and unlicensed mental health clinicians, and it's always possible that as those positions get filled and those program needs get met, that future opportunities will arise that will enable you to transfer. Sure, that's not going to really make you super happy, but it's always a challenge to balance an area's needs with supporting our employees and their own desires and wellness. If there's significant wellness issues, you should certainly talk about that with your supervisor and human resources. But in terms of routine opportunities to transfer, that's always been the department's policy, that your ability to transfer is based on program need. And I don't anticipate that changing, particularly in the time of the pandemic when we're so desperately trying to continue to meet the needs of the people we serve, and where we're short-staffed in areas, we just have to really balance those two very challenging competing objectives. And again, I know that might not satisfy you, but I hope that you appreciate that there is a rationale behind it, and that's where we're at. All right. All right. Another question. What is the best guesstimate about when we will be able to burn our mask, kiss strangers at the market, and quit washing hands again? I would predict that it's not going to happen for a while. And here's why. The vaccine rollout is not going as quickly as planned. Light is certainly at the end of the tunnel. One of the good things I think that's really happened is this surveillance and the general public's recognition of what public health surveillance is all about. I would guesstimate that in future years, particularly as we anticipate that COVID will stay around, there's almost no way we're going to completely get rid of COVID. There's lots and lots of people who refuse to get vaccinated for all variety of reasons, and parts of the world that will struggle to get their populations vaccinated for all kinds of reasons. And so likely COVID will stay around in one way, shape, or form. And so there will be some, I'm guessing, winter precautions or year-round precautions that won't be mandates, but will advise people that if you're going to be in large crowds, wear a mask, wash your hands, that kind of thing. And so I would guess at least for the next year or two, there'll be some guidance in that regard. I think we'll get to a point sooner rather than later where stay-at-home orders won't happen, and the focus and attention on the daily numbers, this update will go away maybe because we're in a better place. I hope so. I hope you stop seeing so much of me. But I think it's going to be a while, certainly not until the end of this calendar year, I would guess. I think we'll get back to normal in the ways we think about being normal within that time frame, but that will really depend on availability of vaccines, people's willingness to take the vaccines, and no unknown mutations happening that really upend the work that's been done. And then the other thing I hope that the public and all of you realize is that these viruses like COVID-19 happen all the time in our environment. And likely COVID-19 has been around a lot longer than last year or the year before. And it's possible that it jumped from an animal to somebody working in a field, and that person got sick and got better and never passed it on to anyone, and that little variant died out, and then later it went to someone else. And then the perfect storm emerged where it got in a population and then it spread. And so viruses like this have been around for many, many years. I mentioned earlier, we have Ebola, we've had the swine flu, H1N1, and other types of influenza variants. This is going to keep happening because this is the world we live in. And so we may have to get used to some degree of wearing a mask when we're traveling, or practicing social distancing for a longer period of time. I don't know. And I think that the sooner we can come to be at peace, to resolve within ourselves that we can enjoy our lives and we can participate fully in our life, and that mask or that social distance isn't the imposition that, maybe dying of a virus would be. So that was way more than you asked for, but there you go. Yeah, someone else said, well, we were always supposed to wash our hands and such. And a lot of people have asked, a lot of conspiracy theorists have said, and where did the flu go? Well, guess what? All these precautions we've been taking actually worked with the flu and probably would have worked last year and the year before and every other year. But we're such an independent group, we wouldn't possibly be inconvenienced to protect each other from the flu, let alone COVID, which is much more prevalent. So, sorry, little sarcasm there. So, these are precautions that work. Viruses have been around, they're always going to be around, you're always going to be exposed to them, and if your body hasn't dealt with it before and doesn't have antibodies, you're going to get it. So these precautions protect all of us against lots of different viruses, and might be helpful in the future if we get a little bit used to following them. Okay. I think that's all the questions for now. As usual, if you come up with a question and didn't get it in the nick of time, or think about it later, or something I've said is troubling you or makes you think about something tonight when you're trying to go to sleep, please email and we will be more than happy to get you an answer to your question. And I will see you next week.